Okay. Good morning.
Good morning.
I'm Dr. Akram, specialist in cardiology. Can I confirm that I'm talking to Ms. Sumaya?
Yes, I'm Sumaya.
Yeah, I just have refer letter from your GP. He said you loss of consciousness. Can you tell me more about that?
At that day, I was exercising on treadmill machine, and suddenly I lost my consciousness. I didn't feel anything before that.
Okay, I will do a more detailed question. Is it all right for you?
Okay, no problem.
Okay, when you just you fell at that time.
Can't hear you. Can't hear us.
Okay, I will give you a more detailed question. Is it right for you?
Yes, it's right.
Okay.
Yaman, can you please mic yourself in case hear you? Yaman,
Yes, yes.
can you please mute all other mics except for yours?
Okay, it's already closed. Already closed. It's except for us.
Mute everything else except for your mic.
Maybe دكتورة عزة phone mic.
Can we begin now?
Can we restart again?
I can hear you. Yes, please.
Yeah, it's okay.
Yes.
مش انت واضحه اسمك يلا خلاص يلا دكتور اكرم شوي يلا
I will give in more detailed question. Is that all right for you?
It's right.
Yeah. When you just fail, did you hear something or see anything?
As I remembered, I feel that some dizzy and then lightheadedness and nausea, and then after that I didn't feel anything.
I mean, do you in consciousness? When you were in consciousness, did you hear anything? See anything?
No, nothing.
No. When you said you collapsed, did you have palpitation, chest pain?
I didn't remember anything from that. I didn't feel anything.
Yes. For how long did you lose your consciousness?
As I remembered, I just when I collapsed, I just when I opened my eyes, I saw my husband running for me, and he said it is just second.
Just
To,
second.
yeah.
How many times?
It's the first time for me.
What did mainly you were doing before you get collapsed?
I was exercising on treadmill. Yeah, on treadmill. Yes.
Yeah. During unconsciousness, you said your husband was there beside you.
Yes.
Witness you. Did he say you jerking your limbs, biting your tongue, urine incontinence?
Nothing from that it happened. He said just I'm closing my eyes, and
Okay.
then I woke up again.
Did you hit your head?
No.
Head trauma precede you just
No.
loss of consciousness?
No.
Okay. For most when you loss of consciousness after that, did you feel you said you wake early?
Yes.
Quickly. You didn't hurt yourself?
No, I didn't hurt myself.
Okay. After that, did you feel you have limb weakness, numbness?
Nothing from that.
Did you aware where were you?
Yes.
Did you know your husband?
Yes, I know
Did
him.
you know where exactly where you are?
Yes.
Okay. Did you have ever previous similar attack before that?
No,
Yeah. You didn't have chest pain,
nothing, just
palpitation?
nausea and lightheadedness, I think. Like flashes in my eyes.
Uh, that's it.
That's it.
But you said you have before that you feel dizziness like
Seconds of
just
dizzy,
second
and then I
before that.
collapsed.
After you just collapse, what did you feel exactly?
When I woke up, I feel my heart is running.
Yeah,
Uh,
rising up.
yes,
Was your body.
I didn't tolerate that feelings. So my husband called 911 and then took me to hospital.
To hospital.
Yes,
Did you try to count it?
I didn't
You
try.
did. Uh, did you feel it regular or irregularity?
I think, as I remembered, it was regular.
That was a first time for you.
Yes, it's first attack for me.
Then what they did, how did end it, that palpitation?
When we arrived to emergency room, and they did some investigation for me and record my ECG, they decided to shock me. At that time, they shocked me after sedated me by giving me IV drug. After that, I woke up and I was well.
You feel yourself fine
Yes,
after
yes.
that. Okay, did you have past history of cardiac disease,
No.
rheumatic heart
No.
disease, heart
No.
disease?
No,
No. Neurological disease, skin,
nothing. I'm radiately
stroke,
well.
epilepsy also?
No.
Epilepsy?
No,
Diabetic, hypertension?
no,
How about family history? Do you have family history of cardiac disease, sudden cardiac arrest, arrhythmia in your family?
no. My parents were well. I think.
You have
No,
brother,
no.
sister?
Also, my brothers and sisters.
They are well. Okay. You already married?
Yes, I'm married.
Yes. How many
Um,
children do you
I
have?
have one child, son,
Yeah.
1 month old. Here,
Okay.
yeah.
Okay. How was your pregnancy?
It was smooth, but smoothly.
Vaginal delivery?
Yes,
Yes.
vaginal delivery.
You didn't feel during pregnancy palpitation, shortness of breathing, lower limb, swelling?
Nothing. My pregnancy was passed smoothly.
Okay. About socially, do you smoke?
No,
Do you drink alcohol?
no,
Never.
nothing.
Okay. How about hobbies? Do you have hobbies other than exercise?
Exercise, swimming.
You swimming also?
Yes, it's my hobby.
Exercise 3 days a week?
Daily, at least twice daily,
Intensive,
twice per week.
intensive exercise
Yes,
like running?
running on treadmill.
Interesting. Okay. Uh, okay. So that's Ms. Sumaya. And we will do further investigation and we will explain to you after the result of an investigation.
Okay.
Okay? But before that, I will do to examine you. Will you let me to examine you?
Okay.
Okay.
Can I just add something to the questions, Dr. Akram? Did you put, do you know,
Yes, Surah.
did she get her COVID vaccines or did she get COVID or suffer anything?
Vaccines.
Vaccine, I didn't ask her about vaccines.
Yeah, COVID. Did she have COVID? Because a lot of people that are coming to the clinic now complaining from tachycardia. I personally had tachycardia. Got to be 210
Yeah,
pulse.
no history, no
No
history.
history, no.
She
No
doesn't have
history.
any.
Yes.
Dr. Azza, are you here? Dr. Azza? Dr. Azza? Are you seeing tachycardia in your clinic for vaccinated patients?
لا اضغط.
Are you still with us?
Yes. Yes.
Are you seeing tachycardia in patients after the COVID vaccination?
We have a lot of echo, Dr. Mona. We can't understand.
Interesting not. احنا ما قلناش. We did it complete. ليش ما ظهرت يا دكتور؟
Dr. Amna Aloush and Dr. Azza, I'm not sure.
إيه معاكم.
اصبر لحظة.
Are you seeing tachycardia post-COVID vaccination?
We are not seeing the.
Because I'm seeing it a lot in the clinic. People that have tachycardias.
دكتورة منى, can you see our screen?
Our,
Yes.
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 The PowerPoint.
Okay, yes. I can see it.
خلاص يلا نمشي منها.
اوكي.
لحظة. ويني؟ نمشي بسم الله من هنا.
Can you use just one speaker, please? Turn everything else off. Just use one speaker.
اوكي. one speaker, okay. In the examination at ER at that time, patient heart rate, her heart rate was 20.
بعدين السمري عديها كيس أناليسيس. كمل الإكزامينيشن.
Yes, when they exam her firstly, in ER, patient was, her heart rate was 20 per minute, blood pressure it was 80/60. She was pale and fatigued. Her lungs were clear at that time. Heart, it was tachycardia with no murmur. Abdomen, it was soft. ECG at ER. This is the first ECG. As you see, wide ventricular tachycardia in left bundle branch morphology. That's mean originates from right side. DC shock was done for her. Today in outpatient, when I examined the patient was conscious, oriented. Her heart rate it was 66, blood pressure 100/60. She appeared well. Regular venous pressure was normal. Her lungs also clear. There is no murmur. Neurological system also it was negative. No lower limb edema. Investigation. We did the investigation. CBC, renal function, liver function, thyroid function, all of these function were normal. The resting ECG cardiovergence, as you see, there is T-wave infection sinus and erythema about 70, and there is T-wave infection and epsilon wave. Echo show normal left ventricle, mild right ventricle enlargement, mild RP dysfunction, and mild tricuspid gel. Question: which the following is best next about our case? Cardiac MRI, electrophysiology study, tridimensional stress test.
Dr. Mai, are you still with us? Dr. Mai? Dr. Mai?
Into our case, which
Did you have an explanation for right-sided affection? Be something congenital?
There is
Dr.
too much
Az?
echo.
Dr. Aziz, Dr. Amna, do you think, can you comment on the right side?
The ECG is typical of for right ventricular dysplasia. You know, so cardiac magnetic resonance imaging is for me the best next step.
Egyptian team, please. See.
I go. Okay.
The answer is cardiac MRI. After suspect arrhythmogenic right ventricle cardiomyopathy, cardiac MRI perform. Conclusion. Reports note affected triangle dysplasia, but most consist with correlate clinically. Triangle dysplasia refer to combination of which of the following structure? Is it epicardial subtricuspid region, tricuspid isthmus, and RP outflow tract, or left-right and non-coronary cusp of the aortic valve, or epicardial subtricuspid region, RP basal anterior wall and posterior left ventricle? Which is the answer?
Dr. Muna?
Here.
Hello?
Hello?
Yes.
Can you share us your answer?
See?
Okay. Tunisian team.
C.
Yeah, you are right. Epicardial, this the triangle as you say. Epicardial subtricuspid region are free basal anterior wall and posterior left ventricle. 3. Which the following main criteria from update? Not the last one, the oldest one, the updated criteria. 4. Arrhythmogenic right ventricle cardiomyopathy. Regional right ventricle akinesia on transthoracic echo, or non-sustained ventricle tachycardia with left bundle branch morphology and superior axis, or epsilon wave. Which one is minor criteria?
Tunisian team?
I think B. I'm not sure.
Answer is C, epsilon wave. On diagnosis of arrhythmogenic right ventricle cardiomyopathy, there is no single diagnostic test for that. Diagnosis required at least more than of the following: echo or MRI structural features, ECG feature, epsilon wave, T wave inversion, prolonged QR with slow S, absolute feedback, sustained or non-sustained with left ventricle, with left bundle branch block morphology, or frequent BPC. Family history of arrhythmogenic right ventricle dysplasia or cardiomyopathy or sudden death. This is from American Odd One at 2010 criteria: ECG repolarization, T-wave inversion with the outright bundle branch block, ECG depolarization, epsilon wave, histology also, or ventricular arrhythmia, left bundle branch superior axis, negative P1 and in inferior leads. Family history also.
Sorry,
So-
but where it's mentioned that epsilon is a minor criteria?
I will. This is the new criteria, international criteria measured about imaging, regional or global dilatation or hypokinesia. One minor one is regional akinesia in RP. Clinical feature of arrhythmogenic right ventricular cardiomyopathy typically present with palpitation, syncope, or cardiac arrest precipitated by exercise. The first presentation symptoms may be sudden cardiac death. Over time, surviving patient develop feature of right ventricle failure, which may progress to severe biventricular and dilated cardiomyopathy. Usually family history of sudden cardiac death. ECG feature epsilon wave, it was finding in 30% of patient wave inversion, prolonged S, localized QRS widening, paroxysmal feedback with left bundle branch morphology.
So
This is-
epsilon wave is not a minor, it's a major.
It was major in new criteria is minor. I will yes. This is the epsilon wave. Delay is you like it. It's follow QRS and followed by Q wave inversion. Delay is stroke. Also, the minor epsilon wave reproduce low amplitude, as you say in ECG, prolonged S wave also. This is the new criteria. Minor epsilon wave, not more major. Now it's minor criteria. This is ECG, also the same epsilon wave and the prolonged S and wide QRS with left ventricle with the left bundle branch. Major criteria depend on frequent ventricle extrasystole, thus mean left bundle branch morphology. This is during the TTAC. As you say, wide QRS, regular with uh, left bundle branch morphology and fragmented also there and superior axis. How can we originate with the originate and axis on this picture? You say when the inferior leads positive, that means inferior axis superior origin. When they are negative, that means superior axis and inferior region. This is for more detail. Differential diagnosis. Differential diagnosis to transit loss of consciousness, non-traumatic transit loss of consciousness syncope. Our patient was on syncope. Is it reflexive syncope, orthostatic hypotension, or cardiac syncope, or epileptic seizures? Other due to head trauma, psychogenic or rare causes as vertebro-basilar TIA and subarachnoid hemorrhage, cyanotic death. That's it. Reflexive syncope, usually long history of recurrent syncope and partial occurring before age of 14, after inhalation, sight or sound or smell, prolonged standing during meal, syncope due to static hypotension well or after standing. Our patient was on exercise, that's more doing with cardiac syncope. Cardiac syncope also we have more differential diagnosis. Heart block or structural heart disease, valvular heart disease also, or another arrhythmias we will mention. The most important differential diagnosis is right ventricular outflow tract tachycardia. That means idiopathic, or another name idiopathic tachycardia. Benign arrhythmia originate from the same side from the right ventricle, from a right ventricle, and also in normal structural heart. The same left bundle branch, the difference is inferior axis. Right side also originates left bundle branch, and they said they talk about transition from a small R to a large R in P3 and P4. Also, this one is right ventricular outflow tract from right side. As you say, left bundle branch morphology, the same one, the same first arrhythmias. Broodal R in R wave in P1, inferior axis. Inferior axis, yes. There is also the different one is QRS, usually narrow, not wide like arrhythmogenic right ventricle cardiomyopathy. QRS complex, also no fragmentation. The same, sustained monomorphic feedback. Pushing for the third base in this figure. Does it fashion SVT with aberrancy, capture feedback, or fusion feedback? Okay.
Did you with us? Can you share us your answers? Hello.
We can hear
Dr.
you.
And I go for B.
Tunisian team is B.
Tunisian B, Egyptian.
A?
Same. Egyptian A, huh?
Answer is B. Capture feedback. This is for more
May I
detail.
comment please on this ECG?
Yes, please do.
Go back, please.
Would you say
Yes.
the answer is B? This is for more explanations. Imaging. We came to imaging.
Dr. Amna, would you like to comment? I'm not
This is
would you
inferior
like to comment?
ECG. To explain why it's a capture, it's not a fusion.
Yeah,
Can
I
you
will.
please back to the from?
I think it's important to see the. Please go
Okay.
back to the ECG, please.
Can you bring the ECG back?
Okay, I will. Okay, I will.
Yes.
The second one is fusion.
Yes,
Fusion.
the second.
Third one is capturing. The second one is.
I will explain, please, if it's possible.
Uh, no, capturing feedback, as you say in this one.
The second beat is mixed between the normal beat and the one beat of the VTAC. But the
If we are
second.
looking, please excuse me.
I will.
Yamaka, do you keep the speaker on, turn off everything else, please mute everything else? Yaman, can you
Yes,
mute your speaker?
The other,
Nothing.
please.
Sorry.
The other slide.
Go back again.
Go back to the ECG. No.
Before that. You
Before.
want one more?
Yes.
ECG.
Yes.
ECG.
This is a strip of white QRS tachycardia. If we are the last 4 beats, yeah, there are 4 white QRSs, and that's
Yes.
that's suggestive of VT. And if we look more closely, please mute your.
Okay.
Please.
What you say?
I'm explaining. Please let me speak.
Okay, go ahead.
Please mute your mic.
I'm not. Can you keep on speaker? getting echoes. We're getting echoes.
We have only one. Have only one.
Yemen, do you have more than one laptop on? Can you mute everything? Can you mute?
Yes.
Yemen, please mute.
Yes, yes, everything is muted.
Mute yours as well.
Yes. You want to?
Dr. Amma, can you try now?
I can't. So the second QRS is not so wide as the other.
We are which is about the third one. Okay.
Can you mute your mic, please? Dr. Akram, mute your mic as well.
Explain the ECT.
Dr. Akram, can you mute your mic? Dr. Akram,
Yeah.
Dr. Amna?
If we are looking closely to the second QRS, is in between the wide ones and the more narrow QRS, and before the third QRS, we are seeing the P waves is conducted to the ventriculus, and this is very narrower QRS than the other QRS. If we but the second one is a fusion complex. It's in between the two.
Fusion. So you think it's C?
The second is the fusion, and the third is a capture. And these two signs are specific to VT.
Okay. Yes. Did you hear that, Dr. Akram?
Okay.
hear that?
Yes.
Thank you, Dr. Amna.
Thanks.
And diffusion, recapture. But you recapture. Diffusion, recapture. Forget about recapture.
Dr. Akram, you can go on.
Okay.
Dr. Amna, thank you.
We continue the diagnosis. Imaging echo feature of arrhythmogenic right ventricular cardiomyopathy. Usually we show in short axis dilated right ventricle, hyper-reflective moderate band, hypertrabeculation, regional RV akinesia or aneurysm. This is how to take measures of RV. There is sphere dilation of right ventricle dilation. There is also apical thrombus. There is segmental dilation or dysfunction. This is trabeculation also, and hyperactive band. This is transthoracic echo, show dilation and dysfunction of the RV. Following question 5. Which the following statement regarding arrhythmogenic right ventricle cardiomyopathy is correct? Ventricular tachycardia in patient with arrhythmogenic right ventricle cardiomyopathy typically has left bundle branch morphology. Fatty or fibrofatty infiltration of the right ventricle is pathological hallmark. Radiofrequency ablation is successful at prevent FTAC. Which one?
Can you give us your answers?
Which of the following statement is I think الفاتي or fibrofatty is a pathological. I will go with D.
Okay.
B.
Okay. Yeah, you are right. MRI criteria: high signal intensity, ectasia of a right ventricle outflow tract, and dyskinesia, valve right ventricle dilation, right atrial enlargement. Fibrosis also is more specific than myocardial fat. This is cardiac MRI. This is fibrofatty infiltration. This one multiple bulging in a right fee. There is also mild dilation. This is advanced case. Mild dilation in L fee. This is the comment as we said, infiltration on picture C. This cardiac MRI video show right ventricle dyskinesia. Six, the last one. Which the following is true about anti-arrhythmic option in arrhythmogenic right ventricle cardiomyopathy? Ventricle tachycardia, the ablation can be performed. Titrate beta blocker one maximum tolerated dose doesn't have clear benefit on survival from major ventricle arrhythmia. Precanite should not be used. Which one is the true?
A.
Okay.
Egyptian. Egyptian team.
I think
The answer is A. Will return back to my patient to explain for him about her condition and take consent for plan and for plan for management also. Okay, let's see.
Did you say our screen? You are seeing us. Hello, Dr. Mona.
Yes, we can see your screen and we can hear you. There's a chart.
Did you see us?
Yes.
Let me see you. We are here today to discussion your results and to make plan for management. Is that all right for you?
It is right for me.
Okay. What do you thought is going on in your case? What do you have any idea?
Have I had a seizure, type of seizure?
Actually, no, not probably, because it was short duration, and there is no history, as you said. There is no aura, no convergence,
Yes.
no living jerking. There is also you were consciousness was fall down, no recurrence attack. That means also you were exercise that's doing with cardiac syncope more. Did you have ever heard about arrhythmogenic cardiomyopathy? Arrhythmogenic right ventricular cardiomyopathy?
No, you means that it is a cardiac disease?
I'm sorry.
No,
I
you mean that
understand.
I have a cardiac disease?
Yeah,
No.
I'm sorry to see you that, and be sure we will be here to help you, and we will always beside you. You will you will to invite anyone to our discussion.
No, I want to understanding my disease before,
Okay.
then you can share anyone after that.
How do you feel? Is it okay? You want us to go on, or you want to
You
discuss
can go
it
on, you
later
can
on?
go on.
Is it okay for you?
Yes. I want to understand more and more.
Yeah, arrhythmogenic cardiomyopathy actually is congenital condition. That means is inherited. You take it from one parents. That means
But my parents were normal.
it might be. It's complex condition. They said autosomal dominant. Even one of your parent carrier can uh, take it from take the condition from him or her. Uh, Actually, there is mutation in one or more gene and in which phenotype of gene. That's why 30% of just familiar. And there is mutation in protein. That's small or teeny particles protein on your cardiac muscles replaced by fibrofatty. That's make right side of your heart weak, and after that become more dilated. That's why this arrhythmia will happen.
I want to ask you. You said it is
You
so-
have,
it is inherited disease.
yeah.
You said like this.
Yeah.
What about my son?
Actually, yes, it can pass to your son. 50-50.
Oh no.
Okay, that's why we will need to consult genetic counselor. Okay, and to make family screening to your father also and to your son, not now, when he will at 10 to 15 years. We will begin with him do regular screening. About you, I will consult with you. We will begin medication as early, and we will give you more advice first of all. Is that all right for you?
Yes, yes.
Can I explain it?
You
Yeah.
can.
About your exercise, we will modify lifestyle. We will restrict your exercise, intensive exercise.
You
Or,
mean
yeah,
I should stop my hobbies?
I'm sorry to say that, but we should do that. Okay.
Oh.
We will advise you to do mild exercise. No swimming at all. No running. Okay. Also driving car. You said you drive sometime. We will not allow you to drive a car at least 6 months because you have like cardiac arrest. That's why we will not, after we will give you medication now, and I will tell you about another than lifestyle. We will give tablets you should take it, and another one is intervention.
This
Is that-
tablet it maybe continue to, with for life?
Yes, it is long-standing illness. That's why we should continue lifelong. And we not enough tablets, not enough. Lifestyle medication, drugs, and maybe we will need later on blood thinning drugs, anticoagulant. They call it anticoagulant. The important one now we will talk it. We will plan for do small procedures called ICD, intracardiac defibrillator.
You mean devices shocked me?
Yes, small machine. That's a small machine. We will insert it inside your chest under the skin. Connect with 2 to 3 wires. Connect to cardiac chamber. That's
Did you mean that device inserted to my skin with the surgery?
not major surgery. It's minor surgery.
Oh no.
Don't worry. Usually do by specialist cardiologists, electrophysiologists. Take 1 to 2 hours maximum, and we will discharge you in the same day. Uh, that's help you to monitor your breath and prevent another attack, episode attack of syndrome or cardiac arrest. It's working with batteries. The batteries life 7 to 10 years. We will give you small advices before the operation and during, and small advice or many advices post the operation, and you have long advice after that. First, we will take your concern and your husband to insert that machine.
I will discuss this subject.
Okay.
First of all, I will think with myself to decide to insert that machine in my chest.
Okay.
And then I will discuss with my husband and return again to you to give you the answer.
Okay.
Thank you for
That's right
saying
for
that to
you.
me.
And
You mean she can't have any more babies?
I didn't understand.
You mean she can't have any more babies from your husband?
Just I want to ask him that because I'm planning for get pregnancy.
yeah.
What do you say about that?
My wife can't have any more babies?
She wants, she
I want
planned
to
to get
to
another pregnancy and babies. She asked me about that. Actually, we will need to consult. We can't verify to get pregnancy, and but we need to close follow up with you, and we will take decision in that with the gynecologist, and we will close follow up for medication. Some medication have an interaction with babies or side effects on babies. Also, when you get pregnancy, 13% of arrhythmogenic cardiomyopathy, they get pregnancy, have arrhythmia through the pregnancy.
Even that device on my chest.
Device, that's why we will tell you about the device. Device is good for you. It will prevent another attack, and it will monitor to your heart rate. Okay, is mandatory for you now. Okay.
Okay. I will discuss this subject with my husband and return
She has to
again.
be on anticoagulants? Does she have to take a blood thinner?
I didn't understand what you say.
Concern.
Does my wife have to be on blood thinners?
She says she.
Can you repeat your question, Dr.
Does
Mona?
my wife have to be on blood thinners?
We can understand.
Marathon, Codeine, Marathon. Does my wife have to be on anticoagulants?
She's a female, he's not a male.
She's female. The case is female.
Does my wife have to be on anticoagulants? She's my wife.
Anticoagulant.
Does she need anticoagulants?
Yeah, she will. She will. Sometimes she will need. Yeah, as we will put her in Kilixan also.
But she can have more babies then or not? Can she have more babies or not? She's going to divorce her. If she can't have babies, I don't want her. Then divorce her. Can she have babies?
I'm feeling. Okay, it's up to him.
Please not, because I'm going to divorce her.
She will discuss
I don't
with
want
her.
her.
I will start it too.
I want to have a child. I want a boy.
She's my husband.
You were the husband.
You have more babies?
Yeah. This is difficult.
There is a chances that she will
There is chances to complete her with her life with no complications. Small percent, most of patients just tolerate with pregnancy. 5 of them, they just heart failure. 13%, they can get arrhythmias. with medication, maybe, yeah, with the medication, maybe she will improve, and with ICD also.
So I can't have a
She,
boy? I can't have a boy?
yeah. We hope that. Even that we would need to.
Shall I continue?
May I continue?
But my husband, you can put in your mind that my child will carry the disease.
Even that she 50-50. Her husband.
Mom.
Yes, there is a chance to get her baby 50% to get the disease.
خلاص هيطلقها هيطلق دي خلاص خلصنا.
No, his kind person. I don't think.
Thank you, Kevin.
Now we will continue to the
We will
presentation.
continue the
Yes, please.
treatment, conservative exercise restriction, pharmacological beta blockers, sutalol, flecainide, amiodarone, interventions as ICD or ablation. This is how persons of any high risk features, the high risk and class 1 cardiac arrest survived from cardiac arrest, sustained VTAC, severe LV or RV dysfunction, ejection fraction less than 35, or right ventricular fractions less than 17. This is the new guideline from European Guidelines 2023. Recommendation beta blocker is the class 1, amiodarone and flecainide and catheter ablation class 2A. About primary and secondary prevention for sudden cardiac death, ICD recommended class 1, reduce sudden cardiac death in patients who have survived cardiac arrest or recovery from ventricular arrhythmia that caused hemodynamically instability, like our patient. Primary prevention also in high risk features, main arrhythmia, syncope, non-sustained VTAC, right ventricular ejection fraction less than 40, left ventricular ejection less than 45, and sustained monomorphic VTAC at electrophysiology. About ICD, class 1 when cardiac arrest or syncope, non-syncopal ventricle sustained VTAC, ICD class 2A. High risk feature also class 2A. About lifestyle adjustment for patient, vaccination also is necessary, life insurance and diet, alcohol use and weight, smoking should stop, occupation. Most people with cardiomyopathy will be able to combine their normal jobs, avoid any work that requires heavy lifting. Some occupation needs more consultation, like pilot or military persons. About exercise recommendation, we class 2B to avoid a high intensity exercise. Moderate to high intensity, also class 3. This is the new guideline, European exercise high intensity and high mortality class 3, competitive cycling, cross country, and soccer, playboard, main running, also basketball, swimming, and the low risk yoga and walking for villagers or transportation. Recommendation about reproductive issue, pre-pregnancy risk assessment should be counseling are recommended in all women, and counseling unsafe, effective contraceptive, which one contraceptive should patient put on, and also they counseling for risk disease of inheritance and recommended for all men, for men and women. Vaginal delivery is recommended in low ejection fraction. Recommended also medication carefully and for safety advanced pregnancy. Therapeutic anticoagulant with low molecular weight or vitamin K or vitamin K according to stage of pregnancy is recommended for patients with AF and cardiomyopathy. Continuous beta blocker in pregnancy class 2A. About the follow-up, it is recommended that all clinically stable patients with cardiomyopathy undergo routine follow-up using multi-parametric approach that includes ECG, echo every 1 to 2 years in stable patient. Clinically evaluation on ECG with multi-modality imaging is recommended also in cardiomyopathy patients. Diagnosis of patients with arrhythmogenic right ventricular cardiomyopathy is important because of sudden cardiac death in young adult, according 11% of all cases and 22% of cases among athletes. The diagnosis is worse in patients with LV involvement. Pregnancy also mostly will tolerate. But in this study, they found 13% of pregnancy in women with arrhythmogenic right ventricular cardiomyopathy were complicated with, as we explained to our patient, they will get arrhythmia. 5% also may be developed to heart failure. Beta also more common in men than women. And also more common feedback in those who have abnormal echo. Case analysis, our patient, it was 26 years old female, no past medical history, came to clinic evaluation, post syncope. There is no family history of syncope or cardiac arrhythmia. In ER, they diagnosed her firstly as broad complex tachycardia and cardioversion was performed to her. Finally, we diagnosed her as arrhythmogenic right ventricular cardiomyopathy, management as beta blocker and plan for ICD. Conclusions. Arrhythmogenic is genetic cardiomyopathy characterized by progressive replacement of RV by fibrofatty issue leading to right ventricle dilation, localized RV aneurysm, then left ventricle involvement in right ventricle apex and anterior wall are most commonly involved. RVD present between 10 to 15 years of age are more commonly in male and is familiar only in 30% of cases. Autosomal dominant with 30% veterans. Arrhythmogenic right ventricular cardiomyopathy also manifest as ventricular arrhythmia early on, then progressive right or left ventricle failure. The take message, home message RV is inherited and the rare case, but characterized by fibrofatty replacement of RV is also important because sudden cardiac death in young individual. The representation can be non-specific, like our case, making diagnosis just with sudden syncope or sudden cardiac death. That's why patient life in this relative and future generation, we should to do family screening. Therefore, is imperative to make thorough search for all possible causes and don't miss the diagnosis. This is the reference. Thank you.
دكتورة منى. دكتورة منى. شكرا بحدث.
Thank you.
Can we start the second lecture?
Solo presentation.
Solo presentation.
Okay.
Very nice. It was a very nice presentation. Dr. Akram, Dr. Asmaya, that was a very nice scenario. I felt sorry for you. I'm going to divorce you, but I felt sorry for you saying. It was a very nice case. Thank you. Thank you very much. You have the sole presentation now?
Yes.
Dr. Amna Alouche, would you like to comment on the case? Dr. Amna Alouche?
It's a very interesting case. I don't have any comment.
Do you think they handled it well?
Excuse me?
Did they handle the case well? Did they cover all the aspects?
They did well. The most important things were said.
Okay, thank you, Dr. Amna.
Thank you for you.
Okay, hormonal causes of tachycardia. Proceed.
Yes. Assalamu alaikum. I'm Dr. Arid. I will speak. Yes, I will speak today about hormonal causes of tachycardia. We will start with the thyroid hormone. The most frequent manifestation is a sinus tachycardia in hyperthyroidism. There is an increased risk of atrial fibrillation, ventricular arrhythmias, syncope, and sudden death. The presence of tachyarrhythmia can precipitate the development of tachycardiomyopathy. For atrial fibrillation, the indication for anticoagulation depends on Chad's spasmoscope.
Can you play it slideshow? Can you play the slideshow? Get a bigger. Can you put it on slideshow?
Okay.
Slideshow. So you can get a
Now?
Yes, please.
هي كانت أول في سلايد شو. عملت عملنا 5. هي. الحين واضحة؟ عندكم واضحة؟
Now?
إذا نخليها على
خلاص
هكذا. مش كذا بس.
When I make it bigger, it is not appear with you.
Okay.
We will continue like that.
I will continue like this.
اوكي. شباب شوفوا دحين.
كيف الآن؟
كيف الآن طهرة؟
خرجنا من المشاركة نغلق المشاركة ورجعنا من جديد.
تمام. كيف المشاركة؟
You can start by
Okay.
هي الآن التظاهر هي تمام.
Yeah, hypertension. Frequent manifestation.
Yes.
Yes, thank you. Much.
Antiarrhythmic drugs such as amiodarone are the thyrotoxic and should be avoided or used with caution in patients with the thyroid disease. Slide show the mechanism of thyroid hormone, how to affect on tachycardia. When increased T4 and T3, its effect on cardiomyocytes and mitochondria, fibroblast, and inflammation signals. All of this led to atrial fibrillation. Next hormone, norepinephrine. Pheochromocytoma manifestation include palpitation in 36% of patients. A recent study of 650 patients with pheochromocytoma seen between 24 and 29 with a result of about 11% were found to have some form of tachyarrhythmia, and 11% of patients develop atrial fibrillation, about 6% develop atrial flutter, and 4% develop ventricular tachycardia. Epinephrine and norepinephrine.
Go back, please.
Yes.
Pheochromocytomas manifestations of palpitations in 36%,
Yes.
right? And then you're saying 10.9% were found
This
to have some form of tachyarrhythmia, right?
in
Which
general,
is it 36% or is it 10.9%?
in general, pheochromocytoma manifestation in 36% develop palpitation, but this another study done from 24 and
You need to
19.
tell us that, Dr. Arish.
Hmm?
You need to tell us that this is a different study,
Yes, this different study.
okay?
The mechanism of norepinephrine, epinephrine and norepinephrine affect in beta 1 in the heart and kidney, lead to increase the heart rate and inotropic force. Sex hormones also affect the heart rate. Women are more prone to dysarrhythmia because increase the progesterone and decrease estrogen during the normal menstrual cycle predispose women to increased frequency and symptomatic burden and duration of supraventricular tachycardia, sick sinus syndrome, AV nodal reentry tachycardia, and postural orthostatic tachycardia.
So would you recommend the oral contraceptive pill or the hormonal injections as contraception?
What?
Would you recommend hormonal therapy for contraception?
Yes, the hormonal contraceptive effect.
عشان كده تسأل كان صحيح
No, 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 no.
No.
Next hormone, hyperaldosteronism. Almost 50% of all patients with primary hyperaldosteronism, aldosteronoma, or Conn's tumors are asymptomatic. If they don't have their adrenal tumor removed, the patients are at 10-fold increase the risk of heart arrhythmias, stroke, and heart attack. About cortisol, I found a study, high likelihood of atrial fibrillation in Cushing syndrome was published in European journal that speak about people with Cushing syndrome are likely at a high risk of developing atrial fibrillation. This last slide and this is the reference. Thank you.
Thank you, Dr. Arish. Thank you very much. Can we do the debriefing really fast?
Debriefing.
Okay. Encourage questions.
Yes, they encourage the questions. Yes,
And personal history,
it's
are you
covered.
more to the 3 or the 5?
I put 5 personal history.
Personal history, to the 5. And past and family history?
Almost okay for. They covered all the.
He asked about her parents and her brothers and sisters, I think.
Yes.
It's yes,
They
good.
did more than 3. Complaints.
Yes, good 4 or 5.
History of present illness. Did they cover the history of the present illness, in your
Yes.
opinion?
Fully covered.
Fully covered. Risk factors.
I put 4 or 5. 4.
Other body systems.
4.
General examination.
12 or 5.
5.
5.
Local cardiac exam.
5.
5. Investigations.
5.
Differential diagnosis.
4.
4. What could they have added? What did they miss? What do you think they should have asked about for the differential diagnosis? Did they miss out on something specific?
No, the first ECG, the basal ECG was
Typical of
typical of ER for right ventricular dysplasia. So
Could they have maybe thought of something congenital deformities in the heart?
congenital or congenital, yes, or
They should have excluded.
non-compaction, and it may be a Chatterjee effect on the ECG.
Treatment.
Treatment, okay.
Patient counseling.
Okay, 4 or 5.
All right. I think, Dr. Akram, you're going to need to cover her husband. He's going to divorce her. So you're going to be subjected to that in real life situations. Dr. Akram, you still there? Okay, case analysis. What do you think, Dr. Amna? Their case analysis.
For the case and
I think they elaborated a lot more than that. It was
the red
they needed to elaborate on the case analysis, do you think?
yes.
That wasn't enough. Okay, thank you.
Thank you for your
Unfortunately, we only have the floor audio today, so we're gonna skip the case go straight. We only have Dr. Mari with us today, so we're gonna skip. We're gonna skip the case scenarios. We're gonna go straight to the case. Windows. لا يا مش طالعة مش هو ده انا فاتحاها بس مش شايفة
كده shared.
Can you see our screen? Can you hear us?
أنا أقصد إن هي shared. Hello. Hello.
We hear you, Dr. Mario.
Can you see our screen?
What about our screen?
Yes, yes, we see it.
Screen is clear, we see you.
Seeing the PowerPoint?
Yeah, just keep it in.
Okay, I will go fastly with our case presentation, and we are sorry for the subtitles of the clinical scenario. Our case presentation, 53-year-old male patient presented to our cardiology clinic for evaluation of intermittent rapid heartbeat and lightedness over the
Sorry,
pulse.
Dr. Marco, we're still in the first track on the presentation.
You are not seeing the okay. Is it okay? Are you seeing the picture of case presentation? It's PowerPoint.
It's PowerPoint. It's the first PowerPoint. You can pass to the second, so I can answer. No, it's not moving. We are still seeing the first one.
Okay. What about?
It's okay now. It's okay now.
Okay. So our case presentation, 53-year-old male patient presented to our cardiology clinic for evaluation of intermittent rapid heartbeats. Over the past 10 years, these episodes occurred irregularly and several times a month and lasted for 1 to 15 minutes. The patient was otherwise healthy and didn't take any prescription or medication or supplements. He had no family history of cardiovascular disease or sudden cardiac death. Patient drank 2 cups of coffee daily, but denied using alcohol or cigarette or smoking. Previously, the patient had been prescribed propafenone and metoprolol as a beta blocker for some of palpitations. However, due to his concern over the potential adverse effects of the drugs he is taking, he chosen not to take these drugs regularly. 30-day event monitoring was performed, and 4 months prior to our presentation was negative. Vital signs and the physical examination are with normal. So we did an ECG for the patient, and I am sharing this ECG. As you see, it's a very super normal ECG, but the main comment is tachycardia. A heart rate is about maybe 2 big squares. So it is normal sinus, but it is sinus tachy. So I would like to ask a question here, like we order also an echo as a formal or a routine labs that we ask, like an ECG, and then we ask it for a Holter ECG and echocardiography. I missed to put another slide that we order more investigation, like the routine investigation we do, TSH, T3, T4, and for sure electrolytes, and all of these labs was within normal average. So the question, or the first question I'd like to ask is, what do you think? Ivabradine alone or in combination with beta blocker should be considered in inappropriate tachycardia? Is it true or false? What do you see? Hello? What do you see? Is it true or false?
True.
Okay. Tunis?
Oh, yes.
According to the guidelines recommendation, as you see, it's a +2 or combination with beta blocker is considered patient's tachycardia. We ordered Holter ECG. This is the result of the Holter ECG. What do you think? The Holter ECG show narrow complex tachycardia, rate of 220 with short interval. Echo.
Can everybody please mute your mics? Can you please mute your mics, everybody?
With short BR interval and retrograde B wave suggests of AV and RT. The transthoracic echo was normal, and there is no structural heart disease. The second question is, in pregnant women, which of the following should be considered in patient with WBW for the prevention of SVT without ischemic heart or structural heart disease? We have a pregnant woman, known history of what do you think? Flecainide, verapamil, ivabradine, atenolol. Which of the following is the best option?
Pregnant. One.
What?
The first.
Okay. Yemen?
You should only have 3 choices, not 4. One. Yemen, what do you think? Yemen?
Yemen?
1-1.
Answer is right. Flecainide is recommended. Flecainide or selective beta blocker can be used in patients with WBW. The differential diagnosis that we could suspect in patient with SVT and even RT, atrioventricular precipitating tachycardia or atrial tachycardia or junctional precipitating tachycardia. Question number 3, DC shock should be considered if the drug therapy failed to convert or control the tachycardia. Is it true or false?
True.
Okay. Yemen?
True. You mean in supraventricular tachycardia in general?
Yeah. DC shock is recommended when drug therapy failed to convert or control tachycardia. It's a class 1B in a stable patient, actually in a stable patient. The management, the patient after Holter, we suggested to underwent an EP study, which identified a typical even RT, and a flow busway ablation was performed, consensus with the current guidelines, and the patient after that, we did a follow-up and with no complaint. Question number 4, what is the first line of treatment in focal atrial tachycardia in hemodynamically stable patient? Atenolol, esmolol, verapamil, adenosine. Focal tachycardia, what is the first line of the treatment focal tachycardia?
Ismilol.
Esmolol. 2.
Okay, this is recommendation for tachycardia. You see, hemodynamically stable patient, we can adenosine can be considered. Beta blocker like esmolol or metoprolol should be considered if adenosine failed. Verapamil should be considered also if adenosine failed. So the first line is adenosine, and then we should go for beta blocker like esmolol or metiolol. As a slide of acute therapy of focal atrial tachycardia, if the patient hemodynamically unstable, if yes, unstable patient to go for DC shock. If no, so we go for adenosine. If it failed, we go for one of the beta blockers mentioned, or if a gramyl calcium channel blocker. If the beta blocker and calcium channel blockers is ineffective, we can go for other choices like flecainide, propafenone, and amiodarone. It's a class 2P.
Can you tell us how you give adenosine?
What do you think about adenosine? There is a shortage actually of adenosine in Egypt, but we know that we can use 3 shots of adenosine. How do you think? Adenosine we
Does
can...
anyone know what the half-life is for adenosine? Does anyone know what the half-life is for adenosine?
Very, very short.
3 seconds. 3 seconds.
So what do you do when you give adenosine? What do you tell them? When you give adenosine to your patients, you have to tell them, I'm not here. Precautions for giving adenosine to your patients before giving them the shot. You have to warn them.
Unfortunately, we don't have adenosine in Tunisia.
You have to warn your patient to be aware that when you give them adenosine, they might be subjected to chest pain. You have to tell them that this is normal reaction and it's due to the drug, and that you're right there by their side to help them out if anything happens. Another thing is that it has a very short half-life, like 6 seconds or something. So when you give it adenosine, you have to use a 3-way cannula. And you have to push it with an IV infusion.
Okay. So bolus doses of adenosine, it can be, we can start by 6 milligram. If it's failed, we can go for more bolus injection, like 12 and then up to 18 milligram bolus. Question number 5, in patient with congenital heart disease presented with acute SVT and hemodynamically unstable, DC is a class of recommendation. Is it true or false? Congenital heart disease, patient has a congenital heart disease and presented with unstable SVT, hemodynamically unstable.
True. The patient. True.
Okay. Have you seen hemodynamically unstable patient in a congenital heart disease patient? DC it is recommended. It's a class 1. This is and the EB study of the patient, and the, here is the induction of the typical even RT. So the EB study was confirms the diagnosis of even RT, and then after doing the ablation, the patient returned with no complaint. Here is some slides of the guideline. As you see, the initial evaluation of the patient with SVT, the standard, we should take a good history and physical examination, actually for sure an ECG and full lab counts, biochemistry profile, and thyroid function. An ECG during the tachycardia should be confirmed and documented. For sure, echo. What's optional is exercise tolerance testing, ECG monitoring, like trans-telephonic monitoring or implantable loop recorder, myocardial ischemia testing in patient with coronary artery disease or have a risk of heart disease, including men more than 40-year-old and postmenopausal woman. It's a routinely, and it can be optional for examining the myocardial disease, coronary artery disease. AB should be considered for a definitive diagnosis when catheter ablation is anticipated. Also, it is a recommendation for the acute management of narrow QRS tachycardia in the absence of an established diagnosis. We can divide it in two major headlines. If the patient is unstable, for sure we should go for DC shock. It's a class 1. And hemodynamically a stable patient, ECG should be recommended. We can start according guidelines by the first line is the vagal maneuver. Sometimes be effective, briefly in the supine position with leg elevation. It's recommended as a class 1B. And then if the vagal maneuver failed, we can go for adenosine. It's recommended. After that, we can go for calcium channel blocker like verapamil, dilatazine should be considered. If vagal maneuver failed and the adenosine also failed, we can go for calcium channel blocker, beta blocker, metoprolol, esmolol should be considered also. And synchronized direct current cardioversion is recommended when drug therapy fails to convert or control the tachycardia. Thank you.
Thank you, Dr. Mario. Dr. Amna, would you like to comment? Dr. Amna, would you like to comment?
Yes, it's a very good presentation. They covered all the topics, and it would be important or interesting to dedicate a whole session for pregnant women with, I think, with arrhythmia and even with heart diseases. It's a patient special situation.
Yes, I agree, definitely. You're right.
Thank you.
Thank you.
Good.
Thank you, Dr. Amna. Thank you for being with us. It was a pleasure having you. And thank you, everybody.
Pleasure.
We meet Dr. Amna, I'm going to be sending you their case submissions for peer review. The tachycardia case for publication, inshallah.
Okay, inshallah. Thank you.
Thank you. Thank you, everybody.